Hello, this is Vicki, and this is the first voiceover in a series regarding vascular problems. In this lecture, we will discuss both arterial and venous insufficiency. By insufficiency, I mean there is not an effective tissue perfusion of oxygen and nutrients. So in order to have adequate blood flow, to ensure adequate tissue perfusion, the heart must pump effectively, and the blood vessels must be patent and able to move the blood through them. There must be an adequate circulating blood volume as well. For most of this lecture, we're going to concentrate on the second part, patency and responsiveness of the blood vessels. So here are the topics that we are going to discuss in this two-part lecture. First, we'll talk about peripheral arterial insufficiency. So we'll think about that interrupted perfusion or blood flow to the fingers and the toes. We'll talk about the lower extremities. We'll talk about amputation, which may occur as a result of tissue death related to ineffective peripheral tissue perfusion. We'll talk about aneurysms that form in the vessels of an artery and why that happens. And we'll also talk about dissecting aortas, aortas that rupture and burst. All of these arterial issues have an etiology of atherosclerosis, and we'll talk about that again in a minute. There are two other arterial disorders that we will discuss briefly that do not have an etiology of atherosclerosis. The first is Raynaud's phenomenon, and that is really an autoimmune disorder, and the second is Buerger's disease, and that is an inflammatory response that often brings on small microthrombi in the vessels that occlude them. And then the final piece of this lecture will be to talk about venous insufficiency, which is a little bit of a different problem. So we're going to start talking about peripheral arterial insufficiency. Remember that peripheral venous insufficiency comes later at the end of this lecture, but I offer this slide so you can do a little compare and contrast. There's a nice table in your text, and that page number is listed down below. Some of the symptoms can be the same in these two vascular problems, but they can also be different, and they're also caused by different problems. So the arterial problems are primarily caused by atherosclerosis, and the venous problems are caused by an inadequate return of the venous blood from the legs back to the heart. Remember that I said the most common cause of arterial disorders, most of them that we'll talk about in this lecture, is atherosclerosis. Now we can use two terms interchangeably. Arteriosclerosis, which is, you might have heard the term hardening of the arteries. So it's a hardening and a loss of elasticity of the arteries. Or atherosclerosis, which is that accumulation of plaque buildup in the arteries. Your book talks more about atherosclerosis, so I'll use that term moving forward. But remember that in arterial problems, either a rupture can occur or an occlusion of that artery. And this results in an inability to perfuse blood that's rich in nutrients and oxygen and ultimately results in tissue ischemia or necrosis. So as we move forward and talk about peripheral arterial insufficiency, we're going to concentrate mostly on the occlusion or the obstruction of the artery. Peripheral arterial insufficiency in the lower extremities usually occurs below the aorta. Later, we'll talk about issues with the aorta. So if you look at the pictures here, we're talking about the iliac, femoral, popliteal, tibial, and also the perennial arteries. That one isn't depicted in the picture, but that one as well. So we're looking at an occlusion here of those arteries, or somewhere in that vascular pathway, or a narrowing due to that atherosclerotic buildup. One of the hallmark symptoms of this that you'll see in clients is something called intermittent claudication. So here's what happens. When the client exercises, and that may just be walking, the muscles are looking for oxygen and nutrients to metabolize at the cellular level. Because there's a blockage or a narrowing, the cell isn't getting enough oxygen, so it metabolizes in a form of anaerobic metabolism, which is not as effective and results in a buildup of lactic acid. So we talked about this in shock. You'll remember that at the cellular level. So here we are, the muscles, the cells in the muscles of the leg are building up with lactic acid. So when the client walks and the requirement for oxygen is increased, they begin to experience pain in the form of cramping, burning, aching. When they stop, the pain is usually relieved because that requirement for oxygen is decreased again. And the pain usually occurs below, or we say distal, to the occluded or stenotic area. Sometimes these clients feel that pain is worse at night when their legs are elevated, so they may sit up in a chair and want to keep the legs below the level of the heart. This is kind of a fun way to look at the risk factors for atherosclerosis and lower extremity peripheral insufficiency. Smoking is a huge problem. Obviously, hyperlipidemia, which goes back to that buildup of plaque. Comorbidities such as hypertension and diabetes that really put stress and strain on the arterial vasculature over time. Being obese, as one grows older, they're more likely to be candidates for these problems. Sometimes more common in women. There is a family history link. Stress, which kind of goes back to hypertension, right? And a sedentary lifestyle, which goes back to obesity. So all of these risk factors set up a client for these arterial disorders, and we'll talk later in treatment about the importance of modifying them. When we assess the client with lower extremity peripheral insufficiency, here are some of the assessment findings that we may observe. So in looking at the skin itself, it may be thin, shiny, very tight looking. There will be a loss of hair growth on the legs. And think about all of this in relationship to a decrease of oxygen and nutrients being being provided over a long period of time. If we think about it in a circulatory sense, we know obviously that there are going to be some issues with our pedal, popliteal, femoral, all the pulses below the aorta, right? And this will help us determine location too. So if a client has a good femoral and popliteal pulse but an absent pedal pulse, we're going to know that that occlusion or that stenosis is somewhere between the back of the knee and the foot. Dependent rubor is an assessment finding that you might see, and you can read about that below in the comments. I didn't see a lot in your book about that, but I did want to include it. Also, cyanosis is another color that you may see. Neurologically speaking, we may see some sensation issues, numbness and tingling, or a complete loss of sensation, or we may see that burning and shooting pain in the extremity. So we have to be careful, especially if there's a loss of sensation, to think about applying heat, to think about shoes that are ill-fitting, because a client, just like a diabetic, with diabetic neuropathy, a client is going to have difficulty protecting their extremity if they don't have a good sensation of it. Also, when the legs are elevated, as I suggested in the last slide, this seems to cause more symptoms and more discomfort. I want you to think about that like a garden hose. Okay, so if you have a garden hose and you are watering your flowers and there is a buildup of leaves and dirt and things from last year, you're only going to get a trickle of water, right? But if you take that hose and now you raise it up in the air over the level of your heart, you're going to get less of a trickle. So liken that to a buildup of plaque in a vessel and then elevating the leg. It's the same type of idea. So it's important to stop for a minute and think critically about the complications that can occur. So if the client has a progression of leg pain, so say they have intermittent claudication, they stop, they rest, the pain goes away, but over time the pain doesn't go away and the pain progresses to a state of rest. So we need to think about that, and think about that in terms of the fact that the occlusion is worsening, or the narrowing. Non-healing ulcers, infections, gangrene. There's a nice picture, the lower picture there of gangrene. These things are a result of a loss of the oxygen and nutrient-rich blood flow, and often result in amputations, which we'll talk about in the next voiceover. We're going to see changes in color and warmth, as we said on the last slide, and a decreased rate of nail and hair growth. I also gave away the question at the end of the slide here, why the leg pain might worsen at night, and we talked about that in the last slide as well. Diagnostically speaking, probably the most popular diagnostic measure is the Doppler ultrasound flow studies. So your book calls them Doppler ultrasonography with duplex imaging. And this is really a diagnostic test done with Doppler using color, and it shows the flow of the blood and the rate of the flow of the blood, and it allows the physician or the technician to actually see the vessel and determine if there is any narrowing or occlusion. We use Dopplers sometimes right up on the floor when we can't palpate a pulse. And so that can be done as well to measure the blood flow. Sometimes it's done during a stress test on a treadmill, and that goes back to that intermittent claudication. Now your book I don't think talks about that, but that would be one way to help to see that intermittent claudication, and when the pain occurs, what's going on and where it's happening. The ankle brachial index is a calculation that's done by dividing the ankle systolic blood pressure by the highest brachial systolic blood pressure. Now, this is not something you will ever do, but you will see that it's done probably in the radiology department, and you will see this value. And so what you need to know about this is the normal value. So you would want to know if it was not within this normal range, and that would help you to know that that's significant of a insufficiency. Also, angiograms, CAT scans, and MRIs can be done to help to assist with the location of the problem. So the Dopplers more look at the pathway and the flow, and these tests more look at where is the problem. Important to know for surgical intervention, of course. As always, we want to think about our clients in terms of the nursing process as the framework for our care. So here are some of the nursing diagnoses on your objectives page, and they are pretty, at this point, they should be pretty familiar to you. So we have ineffective tissue perfusion, and in the case of the lower extremities, we would say ineffective peripheral tissue perfusion. Related to eye-set occlusion, it could also be a narrowing. It might not be a complete occlusion, but as an occlusion, I said the evidence might be absent distal pulses. So just to clarify, a narrowing might be a weakened distal pulse. Acute pain, and that goes back to your intermittent claudication, and that will be related to tissue hypoxia, so not enough oxygen getting to the cells and the muscles, and the evidence would be pain with ambulation. These clients also may suffer an activity intolerance, because if it hurts to ambulate, they may not ambulate, and ultimately impaired skin integrity if there is tissue death to the distal periphery. Some of our goals for nursing care, which can be accomplished in the form of teaching, are to promote vasodilation of these vessels that are becoming narrow or occluded, and to prevent vascular compression, which may occur if the vessel is occluded. So we want clients to understand the teaching session, and so some of the things we can tell them is they would, one, avoid exposure to cold temperatures, because that will cause vasoconstriction. They can use things to warm themselves up, possibly a warm bath. They can use a hot water bottle or a heating pad, but not to the extremity, because remember that loss of sensation. They may not know it's getting too hot. It may result in a burn, and then with the reduced oxygen to that area, it's never going to heal. So what we can teach them to do is put the heat on their abdomen, if they provided that they have good sensation there, and that will help to promote some vasodilation. Clients with peripheral arterial insufficiency are going to be taking some medications also to help them. Now, these meds, most of them should not look unfamiliar to you, and I want to take a minute to say on your objectives page to look for the drugs that are bolded. They are the ones that we will be considering for testing for this this content area, although all of these medications are important to consider for practice and NCLEX study, of course, moving forward. So the antiplatelets are bolded on your objectives page. Some are new, some are not, but they're important to this. So aspirin and clopidogrel are blood thinners, so we have to think very carefully about the risk for prolonged bleeding when taking these medications. So when someone takes aspirin every day, we always think about that, especially prior to a surgical procedure or a fall. We look for bleeding, bruising, so that's a consideration here. Silostazol decreases platelet aggregation, or the buildup of those sticky platelets within the arterial vessel, and it is actually a vasodilator in its action. So again, may cause prolonged bleeding, may cause anemia, and because it's a vasodilator, it is not recommended for clients who have congestive heart failure. So it's important to keep that in mind. The statins, I think that goes without saying why you would need a statin to reduce that buildup of plaque. Analgesics may be used for leg pain, and the supplements are interesting. So vitamin E is an antioxidant, which could have an important function here in wound care, and then vitamin C and zinc, you'll probably remember from other lectures, helps to strengthen the cell wall, so they promote cellular growth and ultimately healing. So these are some of the drugs that you will work with your clients and teach them about, and they will probably go home on some combination of these medications. Here is some additional planning and teaching that you'll do with these clients. First and foremost, we want them to look at their lifestyle, and can they control or manage some of those risk factors that we talked about in the beginning of this voiceover. So smoking cessation is very important. Their ability to manage stress, controlling their weight, getting exercise. These are all things that will help to modify those risk factors. We want to teach them to protect their extremities, to avoid trauma, to wear good, well-fitted shoes, not put anything constricting. I know from years of working in long-term care, little old ladies like to put rubber bands at the top of their knee-high stockings to hold them up. Not a good idea, right? Will constrict the blood flow. Keeping the legs lower, not elevated, is also a good teaching intervention here. We want them to look at their lower legs and their feet every day. Do they see a sore beginning or a color change? This is important for them to report. This is a reportable sign because this is the beginning of a problem, and we know that if they have a sore, it's not going to heal well. They want to get right in touch with the provider for more intervention. Other lifestyle changes include dietary inactivity. So of course in the diet we want to decrease saturated fats, decrease salt consumption, obviously decrease cholesterol consumption. We want to encourage them to eat foods that are, consume a diet high in fruits, vegetables, and whole grains. Getting a little tongue-tied here, guys, sorry. In terms of activity, even though walking may be painful and it seems like a bit of a disconnect, we want them to do it. We want them to work up to it, because if they walk, that will help promote oxygenation. So what we have them do is slowly, progressively build their walking. They need a warm-up period, and then we want them to walk until they feel pain. When they feel pain, they stop and rest till it goes away, and then they start again. Their walking should be built up to about 30 to 40 minutes a day, 3 to 5 days a week. And if they slowly, progressively do this, this will promote the blood flow to the distal periphery. Okay, so this is the end of the first voiceover. In the next voiceover, we're going to move in and talk about surgical intervention and amputations.